Before your presentation starts, I'd like to take a few moments to introduce you to the City of London Dental School. We're a private postgraduate dental school based in London and run from our college facility at Southgate. Here we offer a number of various programs, both short and degree programs. At present, we offer 6 MSc titles validated by the University of Bolton. These include clinical dentistry, orthodontics, periodontology, pulpal therapy and endodontics, restorative and aesthetic dentistry, and the specialist practice of restorative aesthetic dentistry combined with implantology. These are delivered from our state-of-the-art teaching facilities, and to be introduced shortly are 3 more new titles. We're also introducing the MSc in the specialist clinical practice of aesthetic non-surgical interventions. This is to do with facial cosmetics. The MSc in the specialist practice of computer-guided implantology. This is implantology taught from a digital perspective. Also a combined MSc of restorative aesthetic dentistry with implantology. These programs are all taught from our laboratories where hand-on experience is required, where delegates get the opportunity to use the latest digital equipment, printing materials, scanners, and also to practice prep techniques on phantoms. Our short programs are in topics such as implantology, restorative, and orthodontics. These programs normally last anywhere between 4 to 12 months. We also offer clinical internships in the UK and the UAE, where delegates get to treat patients directly. In addition to this, we offer diploma and certificate programs. These programs are at HE level 7, so they're university certificates, which means that they can be used towards MSc programs, not just MSc programs that are offered by the City of London, but also other programs. So thank you for sparing the time to listen to this presentation. If you want any more information, then please contact us at info@cityoflondondentalschool.co.uk. I hope you enjoy your presentation today.
Morning, everyone. Right, okay, so I've been asked by Stuart and the City of London Dental School, so thank you for the invitation and the sort of opportunity to share with you a sort of a journey now, and something that I think you will start to see more and more as part of your daily workflow, especially with digital now growing and becoming certainly a tool in the practice that not just from a clinical perspective, but also from a patient journey perspective, really does improve their experience. So I'm just going to share my screen with you. So what we're talking about today is something called Modjaw. It's a 4-dimensional jaw tracking device. And the question that's always interested me was reconstruction or restoration of teeth versus rehabilitation. Do we actually improve our patients' masticatory system? Do we actually achieve what we really want to achieve? So let's get started. Like I said, questions, guys, I don't put them in the bottom. I'll deal with them at the end. So looking at sort of how we get them from point A to point B there. So that was sort of my vision, really. I wanted to imagine a world where I could actually improve the patient's masticatory system, you know, actually rehabilitate it. But you've got to be able to understand the system, and you've got to understand the challenges that have come about over the last 120 years of occlusal teaching. So a little bit about myself. I'm 20 years qualified now. I'm a specialist in prosthodontics. I trained in Manchester, finished that around 2011. I've done a master's in philosophy. I've done my research in restorative as well. I run a clinical practice, a specialist referral centre here in Manchester. With that, coupled with that, is the education arm. I do a lot of examining, and I work at the dental school in TMD. That's my interest. And another interest is soft tissue management around teeth and implants. So I recently finished a master's with Giovanni Zucchelli in Bologna. That was really quite an interesting 2 years. So coming to restoration, I think when we look at the past, what we used to do when patients lost a limb, we would just give them something that gave them an aesthetic replacement of what they'd lost. It wasn't truly a functional replacement. And we sort of developed things within that, especially myoelectrics, where now we are connecting them to a neural and muscular pathway. And so now we're starting to rehabilitate our patients that have lost a limb or lost soft and hard tissue. When we think about that same process in dentistry, you have restoration, which for me is the mechanical devices that we use today. And even digital are simply a replication of what you do analog. But I want to look at devices that actually we can start to assess our patients. Our starting point, do we actually know what the patient's starting point is? And therefore, have we either kept them the same, have we made it worse, or have we actually improved our patient's system? So at the moment, what you do is you provide an occlusal scheme that's driven by the articulator and its settings. You provide bite records to aid that process. You also use reference planes that have been calibrated on a human to fit to the articulator. For example, Frankfurt's horizontal plane or the plane of horizon. These are all very fixed reference planes on an articulator, which we transfer to the human. But actually, do you really look at how the patients chew? When you introduce something, do we actually reduce their functionality? Because you've introduced something into the system, and because the patient is adaptable, they simply reduce their functionality so they don't cause any problems to themselves. So have we then really rehabilitated the patient, or are we just restoring the patient? So what I'm trying to share with you is an analysis of the occlusal scheme that is designed to at least maintain their existing chewing cycle, or why not try and improve it? How do we do that? What objectives do we need to do? We need to obviously look at the health of the patient to see that we are improving it or making it worse. Because that is your job. You are a healthcare provider and you come under that umbrella, and that's what we do. We want to improve the health of the patient's mouth. You know, when you do a crown, why do you do it? Are you doing it for financial reasons, or are you doing it for health reasons? Now, financial will always be a part of that, so there's no doubt that there's an incentive there. But actually, your objective is always to improve the health of that tooth, and there's caveats to that. So when we look at the system, we need to really break down the system and understand how it works. So you have a very basic analysis of this. This is the periodontal mechanoreceptors that are present, and they are stimulated through swallowing and chewing. When they are stimulated, you even want to understand which ones are more sensitive, incisors versus molars and so on. But that stimulus goes to the brain, and that enters through the ascending pathways up into the pons and the medulla oblongata. Within that is the central pattern generators. And central pattern generators are really important because they are part of your system which deal with movements that are subconscious. They're in your unconscious. You don't think about it. You don't think about chewing. You don't think about swallowing. You don't think about locomotion. You don't think about respiration. You don't think about going to the bathroom. You just have triggers. You go, you do what you need to do, but you don't think about it. So these central pattern generators are really quite important. They also feed back to the muscles. So that feedback to the muscles is what gives you force. It's what breaks your food down. It's how you know not to chew soup that has nothing in it. It's liquid. You just simply swallow it. You also know that you don't need to put a lot of force when the food is soft. So when you're eating fish and it's soft. But if you're eating fish and you suddenly find a bone within that fish, you have a reflex arc. You suddenly open. Your brain triggers. You want to investigate that hard tissue and remove it. But from that process, you also learn. We have feed-forward learning, which is part of your cerebral cortex and your cerebellum. I remember the first time I tried snails. And so I put the snail in my mouth. I was trying to savor the taste. And then I was biting on it. The texture was soft. And then once I pierced the snail, there was an eruption of liquid in my mouth. I learned very quickly that I didn't like the taste. So I was putting bread in. I learned a lot about that snail. I learned a lot about from that experience. I had something called feed-forward learning. I also learned that I'll probably not have a snail again. So that's the process of that masticatory system. So we then need to break down what this system actually does. What is the system designed to do? What is its jobs? Well, in physiology, the system is designed for three main jobs. It's designed for swallowing, it's designed for mastication, and it's designed for phonetics. And then you have pathology. Pathology is your parafunction and your hypernormal function. And we are still learning so much more about this field. So when we look at our analysis of this system, when you ask your patient to tap together, when you're assessing occlusion, you're looking at static contacts. When you ask your patient to move their jaw left and right, you're trying to mimic the chewing contacts. That's why we do it. It's the same for parafunction. When they are a clenching patient, we want to make sure our static contacts are good. And when they are a parafunctioning patient with dynamic movements such as bruxism, we want to make sure we get our dynamic movements correct, because otherwise your restoration will fail. There will be a problem. So we start off with that extraoral part of your system. It's why you do extraoral examination first. Why don't you just jump into intraoral? You start with extraoral. Why? Because the driver for your muscles, your driver for your teeth are your muscles in your joint. If this system is unhealthy, how can we treat the teeth? So they are interlinked. We know they're interlinked through the feedback system. So we need to make sure that it's healthy before we start looking at any extensive treatment. When we look at it from an engineering perspective, we say the system is like a class 3 lever, and the analogy is like a nutcracker. So when you have a nutcracker, you always put the nut at the hinge, the fulcrum part. Why? Because the effort required versus the force makes the system that little bit more efficient. It means that they don't need to put that much force to break their food down because the forces are greater there. They don't need to put that effort in. So attached to that system is also a pretty important part. It's the psychological part of your patient, their ability to adapt. And what can affect their ability to adapt? Well, we can look at stress, for example. Stress has other components to it. Our diet is affected when we're stressed. Our ability to heal is affected when we're stressed. Our sleep is affected when we're stressed. So this has an effect on our ability to adapt. When we're ill, we're certainly not as adaptable. As we get older, we're certainly not as adaptable. And then you have this variation between individuals. And this is a life journey with the patient. We have to look at the patient as that journey through their life, and they will have periods of stress and illness, and that will be compensated with their adaptation. When there's stress and illness here, their ability to adapt is affected, and we call that recognition. So this is a little video about the patient who I'd done an upper arch rehab a number of years ago, and then they presented a number of years later.
several weeks ago. And it started by waking up one morning and having really strong pain in both jaws. And it didn't disappear. I took a lot of tablets for it, a lot of ibuprofen, naproxen. Didn't really make any difference.
Strong stuff.
Yeah.
Making you feel?
It made me feel really down and depressed because it was impossible to eat without it hurting for ages after. So consequently, you eat less.
Yeah. Which is not always...
You lose weight, which some people would like, I suppose, but you know, you can't enjoy any food.
So to summarize that, she woke up with a strong pain in both jaws. Painkillers didn't help, but there was a psychological component to it. She was starting to feel down and depressed. So this is the little history of the patient. She started, I saw her in total, probably about 6 years ago initially. And then part of that initial assessment, we came to a diagnosis and a management and a plan, and this is the end point of the plan. These are the occlusal contacts and dynamic contacts. So I like to give group function. We've got good, stable contacts. This is at the time I deliver the final restorations. So then I don't see her for a couple of years because when patients are fine, they don't normally like to come back and see you. But I hadn't seen her for a couple of years. And then she presents after about 3 years. And so this is a review. It's good for me to see the work, see whether what I planned in my head, I've delivered what I wanted to. But what was interesting is her occlusion had totally changed. Her forces had now changed. She didn't have as many static contacts. Her dynamic contacts had changed. They moved on to the premolar pontics. So they weren't even on teeth. They were on the pontics of the bridge. So the question we're asking ourselves is why? Why did that change? Well, it changed because the muscles had changed. She had muscle and joint problems. And when you then get muscles cramp, you get muscle symptoms, that affects the other system. So once we treated the muscles, her occlusion came back again. We are looking much more into the psychological component of our patient. We're looking at their sleep. We're looking at their gut health. We're looking at any blood disorders. There's conditions of restless leg syndrome, which is very similar to power function, and looking at paraneoplastic syndromes. There's iron deficiency anemia. There's thyroid deficiency. So you will realize over time that the patient is a very complex organ. And to say that one thing causes one thing simply is not true. It will be always multifactorial. We want to know the posture of the patient. Is there any cervical malpositioning? Because we know with the cervical spine, if C1 and C0, the atlas, are displaced through muscle cramp, then you have an anterior or posterior displacement of the mandible. That has an effect on occlusion. And we want to avoid causing pain. So what that is trying to tell you is that the system is not stable. It's something that has to be monitored for a lifetime of your patient. To just give them an occlusal scheme and then let them go and say that's it for the rest of your life is unfair to do that to your patient. So when we think about rehabilitating our patient, we obviously need to do a very detailed analysis of our patient. And I'm sure part of your program with the City of London will be to break down each of these components, and then you have to rebuild it. But then once you've rebuilt it in your head, you don't just accept it. You have to reflect upon it. You have to analyze it. Even what I'm going to teach you today, some of you may not agree with. It's an opportunity for you to then delve in and ask the questions that you have in your brain. You want to have an aesthetic analysis because clearly the patient is driven by that, and that will depend on the facial, dentolabial, and dental analyses. And then you have a functional analysis. Please don't ever discount or spend less time on the functional analysis. We need to really understand the function of the patient so that we can deliver the aesthetic result within their functional envelope. So far, we've been using articulators. We've been using face bows instruments to try and replicate the human outside of their body. This is what we've been doing. Is that right? Well, analog is all we had, and on what we have at the moment, we've tried to then make that system as close a representation to what we have. For example, the ear bow, trying to make sure it's, even when it's in the ear, it's as closer to your true hinge axis. You know, so if you're within that 5 millimeter distance, you'll have less occlusal error. So even everything that we've tried to do is to try and make the articulator a closer representation of us. And then this is a historical overview of articulators. Garrett was one of the first to design the first hinge articulator. Bonwell then started to look at a far greater triangle, so looking at Bonwell's triangle and the distance from here to the incisal edge. And then you have Monson's articulator, who looked at this theory of an 8-inch sphere and the occlusal curve of Spee. So we've tried all our best to really try and make the articulator a closer representation of us, but we are not a mechanical device. That is what we had. We've got studies by Shanahan and numerous studies that have tried to look at the mandibular and articular movements to see if they are actually close. And the problem is if you don't give the right data to the articulator, you don't create the same arc of closure. If you don't have the same arc of closure, you will have errors in your occlusal scheme. They will touch teeth differently. Tamaki in 1997 studied accuracy as well, but he was using computerized axiography. And he concluded there was no method used to program an articulator to reproduce eccentric jaw movements. So what that's telling you is that an articulator is great for static contacts, but it's not that good for dynamic contacts. And so if you understand that the system you use has limitations, we start to put other processes in place to overcome the limitations of the system that we have. So your articulator and your face bow have some clear objectives. It's trying to relate the hinge axis of the condyles to the maxilla. You need to place that maxilla centrally within the articulator, so you have a closer arc of closure. If you have a cant, then using a DNR face bow, for example, or your classic face bows will transfer the patient's cant. But if you want to correct the cant, you will use a different art tool like a Coyce analyzer, which gives you the canted corrected. So we're trying to ultimately reduce the degree of correction we need. That's why we use these tools. We use these tools to also design our teeth so that they are functional. So when we look at this patient here and how we analyze, we've put in some parameters to try and replicate that. So one of them is your Frankfurt horizontal plane, because your articulator has a very parallel horizontal upper member. Your curve of Spee or your curve of Monson as well are replicated within this sphere. So we're trying to put or rehabilitate our patient using a mechanical device. And that is a problem. That's a problem because the mechanical device, when it comes to static, good, but when it comes to dynamic, not so good. When we think of curve of Spee, and really quite an important part, it was described by von Spee in 1890. And he analyzed skulls. So his view was he would look through the sagittal and mid-sagittal plane of the skull. And he had several propositions within that. He had three main propositions. So what he was trying to say to patients or to dentists at the time was that giving them a denture type occlusion, because that's what we were doing at that time, we were giving them balanced articulation. And this is where we were then trying to create the Christensen phenomenon, was to try and replicate the curve of Spee. So there were certainly some suggestions, and that was his last point. But again, this was all dealing with denture construction. When we look at the curve of Spee in orthodontics, this is really quite important, because orthodontics certainly try and re-establish that curve of Spee when they're doing their orthodontic treatment. So even within orthodontics, they acknowledge the importance of the curve of Spee. And the curve of Spee is an anterior-posterior curve. So it is from normally the tip of the canine through the distal buccal cusp of the second molar, or the last tooth. But what we've realized from biomechanical studies is that if you give a curve of Spee, then the food processing and the crush to shear ratio between the posterior teeth is increased in efficiency. So curve of Spee actually has an engineering perspective. So we would not want to flatten our curve of Spee, because if we do, we start to lose some efficiency. And you have to remember that the teeth are designed to do that job. They're designed to break down food. So we want to be able to analyze patients' curve of Spee. And this is me using Modjaw, and I can actually analyze the curve of Spee. So we can design the teeth in prototype. So this is the patient in provisionals. And then I'm now using the Modjaw device, and I'm calibrating it. So we're putting in our most distal lobe of the canine. And this has important parameters, not just from a posterior perspective, but also from an anterior incisal edge perspective. And you'll see in this case that I made the incisors too long, because the curve of Spee showed that correction, but also the patient relayed that back to me when he talked about his aesthetics, but also phonetics. So the curve of Spee for me is also an important analysis. And you can see here that I just need to correct it. But actually now it's telling me that my incisors potentially are too long as well. And we can actually correct the curve of Spee using the settings within Modjaw. And this is Monson sphere. So you can see that it's designed as a sphere, because you don't just have the curve of Spee, but you also have curve of Wilson, which is then your lingual positioning of the cusps. And we can then correct it and get the right curve of Spee. So there's me correcting it, and now I've got it going through the tips of the posterior teeth. When we look at the curve of Wilson, this is also really important when it comes to designing our posterior dentition. The contacts and the buccal and lingual cusps of the molars needs to be a lingual inclination through the long axis. This is important from a masticatory perspective, but also important from not creating an interference. So if we make it too flat, if it's made too flat, then the masticatory function is impaired. And this is Dawson's article as well. But also we may create the impairment of functionality may be created by the fact that we've created some working or non-working side contacts. So what that means is when we're chewing on the right side, the left teeth are touching as well. And when that happens, one of the reactions to that is that the muscles reduce the activity. So this is just a case that a patient came to see me, and they'd had their work done abroad, 28 crowns done, and it was done in a week. So they've gone to Turkey. I can say it was Turkey. They went to Turkey. They went for a holiday as well, and they had 28 teeth done. They then come back. After being back about a couple of days, they start to get pain up in the sinus region. So they go and see their doctor. So the doctor assesses and says, well, the symptoms sound like sinusitis, so we'll give you some antibiotics. She'd obviously been abroad, so that link was not something that was incorrect. It would make sense. She'd been abroad, she'd been flying, so there could be a risk of some infection in the sinuses. So he gave her some antibiotics, but her symptoms didn't go away. So then she goes back to see a doctor, and he gives her some steroid spray, still trying to confirm the diagnosis is sinusitis. Symptoms don't go away. She goes back again. He then prescribes her prednisolones, and now he puts her on some oral steroids. The symptoms don't go away. And she had simply not made the link that all these symptoms started as soon as she had her teeth fitted a couple of days after. So when she came to see me, she's now made the link that actually maybe it could be the teeth, because this is what I had so soon afterwards. So when the patient moves to her left, what we notice straight away is that actually the palatal cusps and the lower lingual cusps are what are giving guidance. So her curve of Wilson is incorrect, and you can see from this digital scan that the lingual cusps, instead of being lingually inclined and therefore being slightly lower than the buccal cusps, especially on the right side and on the left side, they're all higher, and also in some of them just the same. So if we look at just a digital analysis of this, you can see in a minute, once it becomes transparent, that actually when she's chewing on one side, the lingual cusps are now guiding the jaw in, instead of the buccal cusps guiding the jaw in. And so she has reacted to that. So all her symptoms are muscular. Masseter is what's inflamed. So the reason why the doctor's thinking sinusitis is because the pain is from the masseter muscles. So you can see here, when she starts to chew on the right, on her left side, so this is looking at the patient, it's the patient's left side, you will start to see in a minute now. So I'm just correcting that, and now look. So you'll see both the palatal cusps need to be prominent cusps as well, but it's on dynamic when they chew that she hits the lingual cusps. So you'll see here, when she moves the jaw to her left. Now, the other problem she has as well is she has less occlusal contacts. The only teeth touching are 3 teeth. So you see here, when she moves to the left, the guidance is off the lingual of the lower cusps against the palatal of the upper. So that is because our curve of Wilson is incorrect. And this is why it's important to see this, that we get the curve of Wilson correct for our patients. So you can see here as the patient moves, and then the canine comes into play. So you saw on that picture as well, the canine was also involved, but it was involved beyond the functional envelope. There are still some analog tools that can allow you to replicate both curve of Spee and Wilson. It's called a Broderick flag. So if you are using analog tools at the moment, then you can use the Broderick flag. When we look at the articulator settings, they've all been designed to be pre-formed, preset for you. So your horizontal condylar inclination is set at 25 degrees if you're using DNAR. Some others use 30 degrees. When it comes to any immediate side shift, there's 0 millimeters, so that you have no immediate side shift. And when it comes to progressive side shift, we set it at 7 degrees. The reason for that is so that we have what are called average value settings. Because when we look at the studies, POSSL being one of the big studies that looked at it, you found that there was a standard deviation from the average value, from the mean. So the mean from POSSL's envelope was between 35 and 37.5, and then you had a standard deviation of 15 degrees either side. So that means your patients could have anything up to 52 millimeter horizontal condylar inclination, and anything as low as 20 degrees. But we set an average. And the reason for the average is so that your cuspal angles or your cuspal heights are all very shallow. If you create shallow cuspal angles, then how are you designing the teeth to chew? You're reducing the efficiency of the teeth. you can do some additional steps to try and improve that horizontal condylar inclination. And one of them was using protrusive bite records. So doing a edge-to-edge bite, for example, or using a pantograph, or using some digital tools such as a DNR Cardiacs, or a SciCat function, or the Arcostigma, or the Zebras. So these were all designed to try and improve the cuspal angle because the teeth are set. Now, if we recognize that getting the condylar inclination, getting the immediate side shift and progressive side shift right, it means you're going to have much more acute cuspal angles, then that would mean the teeth are going to be more like nature. They're going to be designed to break down and break the food down. If you look at the DNR, the maximum horizontal condylar inclination is 60 degrees. Using the Modjaw, what I've done is 10 cases it's now 12 cases so far. And what I found using the Modjaw is that the average, the mean condylar inclination of the right TMJ was 74 degrees and the left was 73 degrees. So that means anything that we use analog is not going to give us what the patient has in the mouth. So if you look at this analysis here of a case, so what I did was I did an upper arch rehab and I made 2 sets of restorations for them. One was designed using average value articulator settings, and one was designed using 4D functional movement data. And you can see straight away some of those differences. Cuspal angles are different, the cuspal heights are different, but even the cycle in and cycle out of mastication are vastly different. So the left for me is nothing like what nature intended for the teeth. So using Modjaw, we import the upper and lower scan. We calibrate the data. I'm not going to show exactly how we do that in this presentation because we've only got a short time. But what you can see here is that once I've calibrated, I can start looking at some of the movements the patient has. I can start looking and analyzing the condyle. So I have on the right side of that Modjaw, we have some axiography data that we would normally see on an axiograph. So you have your interincisal point. We're looking to see. So when you would talk about deviation of the mandible, I may start to be able to see whether there is any deviation, whether it's transient or whether it's a lasting deviation or whether it's an oblique deviation. Let's talk a little bit about canine guidance. And most of you will know canine guidance because you've been taught, but how many of you know who came up with canine guidance? Who was the gentleman who wrote the first or the founding article on canine guidance? And the gentleman was D'Amico in 1958, and he based all his data on anthropology data. So if you're going to offer your patient canine guidance, the question you have to ask yourself is why? Why are you offering canine guidance? If you're going to offer group function, the question you have to ask yourself is why? So when we think about canine guidance, and if you've read D'Amico's article, you will understand that he based a lot of his theory, because this is only a theory, it's only philosophy, that was based on Dr. Gregory's anthropological data. He questioned Black's theory on our dentition, because there was this debate about whether we are a frugivorous diet, an omnivorous diet, or a carnivorous diet, and why the teeth are designed for each way. They used the debate using other species like chimpanzees, orangutans, but also other animal data, looking at their teeth and why those patients have prominent canines. Hector Jones' study on attrition in Aborigines was one of the other theories that he used as well, but that was an environmental work. So what D'Amico was saying was, because the canines were worn away, that's why all the other teeth became worn. And that's not strictly true. But what we've realized looking at a lot of other anthropological data is that canine teeth are part of your masticatory cycle. This is not there's no doubt on this, but actually their main role was determined in sex selection. And what that means is that if you look at a species and that species, the male sex of that species had multiple partners, so meaning that the species was one that would have multiple partners, they would have very prominent canines, because the canines were used to fight off the other male partners. Whereas if you looked at species that had canines that were not so prominent, they were generally singular partners. They tended to just mate with one partner. I think that's important, that we recognize the role of the canine. But then you also have to then delve into which teeth help establish the chewing cycle. And the question I want to ask you is that which teeth erupt first in the adult dentition? It's the first molar and it's your central incisors. Your canine does not come out for another 6 years. So let physiology tell you, let biology tell you occlusion, not a gentleman who's written it in 1958. So what that tells you is that the first molar is what establishes our chewing cycle. It's why you don't see hypodontia of first molars. It's rare. You don't see hypodontia of central incisors. It's rare. You see a lot of impacted canines. Does that mean that that poor patient will never chew properly again if we don't give them the canine guidance? We need to think about this logically. So canines are important as part of the chewing cycle, but you have to understand the chewing cycle. And when we look at Abdu's article in 2015, who reviewed 680 studies, of which 26 were suitable, and I put that in inverted commas for analysis, and he found that there was no difference between canine guidance and group function. So he concluded that patients have the ability to successfully adapt to either lateral occlusal scheme. But there's a huge amount of interpretation bias here. I will very rarely trust a review article which is only done by one author. If I'm going to look at a review article, I want it to be a multi-center author-based review article. So you've got different people coming together and analyzing the data. And that way you're going to get a fair review of it. But where just one person gives the view, I'm incredibly skeptical. The other thing is they've adapted, but have they adapted negatively? Have they reduced their chewing cycle? So have we actually done more harm, but we won't realize it for another 10 or 15 years when they're going through a divorce, or they're going through losing their job, or they're losing their property, or so on, so when they're really stressed. So canine guidance is important. But when you have canine guidance and you are considering giving canine guidance, you need to understand disclusion time, because disclusion time is related to muscle activity. So if you have a steep canine guidance, but also a longer canine guidance, so the canine's quite long, for example, then you're going to have greater muscle activity. But if you make the guidance shallower and shorter, then you will have reduced muscle activity. And this is a great article by Kirstein. So we may want to give our patients who are a power functioning group of patients canine guidance. Do we consider it because it switches off the muscle activity? We recognize that. We recognize that if we give them canine guidance, electromyographic studies have shown again and again, elevated muscle activity switches off. And that's logical, because when I slide to the canine tip, I'm not going to put a lot of force there because my muscles have discluded my posterior teeth. But what about mastication? So these are the type of patients that I will get and I have to treat. So in this patient, she's had orthodontics, and this is not a criticism of orthodontists, but actually a lot of them don't understand function. And that's your biggest problem, when you don't understand function, because you're just giving them a class 1 incisor, class 1 canine relationship. That's your primary focus. So this patient has had orthodontics. We've had the arch realigned, but when they move their jaw to the right, the left teeth are touching. So they have now introduced a lot of contacts that weren't there before. When they move to the left, the right teeth are touching. So here, when they move to the right, they have contact here and here. When they move to the left, we have contact. So we have a lot of posterior contacts now when we're moving our jaw, and you can see here from a digital analysis. So we have also, you see the retainer. So what we've done here, what's also important when we look back at this point, this patient here from this perspective, look at the canine inclination. Look at the way the buccal, the CEJ is protruding out. So the buccal, the roots of those canines are more buccally placed, and therefore the canines are tilted in. Not great. So in this situation, we're going to test whether the occlusion is contributing to the parafunctional activity. How do we do that? We give them a splint. So first, she will get a stabilization splint, and we'll see if we have some resolution of the symptoms. Within that splint, we are introducing a habit-breaking form of occlusion, meaning we have good static contacts on the posterior teeth and anterior, and then dynamic, we have posterior disclusion, because these reduce muscle activity. You see that the contacts are quite heavy on the posterior. So here, after the splint has been done, we see a resolution of her symptoms. So I'm just going to try some simple, irreversible treatment first to see if this will resolve the symptoms. So I'm just going to do some palatal composite veneers to disclude the posterior teeth, and to see if that resolves her pulpitic-like symptoms on the posterior teeth, but also her myofascial pain symptoms. So here I've just designed the palatal composite veneers. So we have the prime scan. So that's the proposal. I have a milling unit in the practice, so I will mill out the palatal veneers. So these are the composite veneers milled from a composite block. Split dam technique. Now, normally I would isolate the tooth, but I can't here because of the permanent retention wires. So now I'm just using a split dam technique. So air particle abrasion, and then you just bond it on with composite. Okay, so now we have our palatal composite veneers. We've given them canine guidance with a short disclusion time. How do you know it's a short disclusion time? Look at the length of the contacts. So we have an ICP, and then when they slide, it's a short disclusion time. So when they slide, now we have posterior disclusion to reduce the activity, but also reduce the symptoms on the posterior teeth, because she's got cracked cusp-like symptoms. So there are situations where we still provide a canine guidance scheme where we're trying to break a habit, and the habit in that patient is one of power functioning, and she's getting symptoms. How can we rehabilitate our patients? Well, to start with, we need to understand the masticatory cycle and how that actually works. So we want to first look at the holistic approach of mastication. Does mastication have an effect on the overall health of the body? So we need to understand the influence of ingestion, digestion, and metabolism, because if we're not breaking our food down, is there a greater effect on our system? How many of your patients are on proton pump inhibitors like lansoprazole or omeprazole. And have you looked in the mouth? What's their teeth like? Have they got multiple missing teeth? Are their teeth worn? Because there's an accumulating amount of evidence that indicates an increasing number of masticatory cycles before swallowing reduces food intake and increases satiety. So we need to have a healthy masticatory system so we're breaking our food down properly. So then you need to understand how the system works and how cusps are designed. So when the cycle in part of our masticatory system is going to come off the palatal incline of your buccal cusp and the buccal incline of your lingual cusp. So it does that. That is cycle in. Forces are not great on cycle in, but it's the cycle out is where the crush and the shear occurs. That's where we break the food down. So our jaw cycles in and it cycles out. Let's show that again. Cycle in, cycle out. So you'll see that the cycling out part is on the lingual incline of the buccal cusp on the lower and the buccal incline of the palatal cusp of the upper. So both your supporting cusps, those are your big cusps, and that's where cycle out occurs. Your so-called non-supporting cusps are important in mastication in your cycle in process. So if we look at this video by Marcel Legal and Roger Yerger, we need to really understand this and then design our restorations so that we can actually deliver a cycle in and cycle out pathway. So then you have your swallowing contacts, which are your static contacts, and you have your dynamic cycle in contacts and your cycle out contacts. So these are your cycle in. You see the buccal and the actual palatal surface of the palatal cusp is your cycle in contacts. And then you have your cycle out, which are your inner part, which is what's going to break the food down. What Legal did in '64, but also Lundin and Gibbs did with the natulator, was we've looked at the analysis of our masticatory cycle. And so you'll have generally four stages with it. So 0 is your starting swallowing position. You open, you move lateral, and then you close in. So 0 to 2 is your cycle in pathway, and 2 to 0 is your cycle out pathway. And so when we look at this, this is our cycle of movement. And Bates is a good article at the bottom there. And so with Modjaw, or with this system, I can actually look at their chewing cycle. And so I will use chewing gum. Once the chewing gum is warmed up, so they'll start by chewing 10 or 15 times just to warm up that chewing gum, making it soft. Then I'll get them to chew on the right side, and then I'll get them to chew on the left side. And then you see I have a shape of that masticatory cycle. So here we have mastication on the right side and we have mastication on the left side. This is my starting point. So I have a good cycle, and this is also the provisional stage. So this is both are identical. So I have not made things worse in this in my new design of the occlusal scheme. So this information from the periodontal mechanoreceptors, it goes to your brain, it goes into your central pattern generators, and you learn about it. So you know, for example, tuna, it has a certain taste, but you know that it's generally soft. You don't need to apply a lot of force. And you also watch your jaw movement to that. So your patients can function in different ways. They can either be a vertical chewer or horizontal chewer. We need to look at their sequence duration, the number of chew cycles, because someone who chews less will also have an effect on their gut, and how much total chewing work is done to break down certain foods. So a carrot will take a greater number of chews, whereas a nut will take maybe less number of chews. So you will have a difference in their chewing according to the food that they're having. But there's also a significant correlation between occlusal surface area and functional surface area of the posterior teeth. And what we've seen is that if you don't give them the right shaped teeth, we will have fewer chewing cycles. So we've got to really give them a good functional surface area so that we can actually break down the food. We want a good cycle out. Now, there's numerous studies, and you can see from the bottom, there's Lucas's and Badil's study. There's other studies as well that look at sleep quality and gut health. And this is important. When we look at sleep quality or sleep pattern, we tend to sleep in 4 stages or 3 stages in REM. And REM is your rapid eye movement. Stage 1 and stage 2 is our superficial level of sleep. This is what we're slowly getting into our deep sleep. And in stage 3 is where a lot of our healing occurs. And that's where you have your lymphatic system flushes away, but it's where a lot of your healing occurs, not just neurologically, but also to your system. So this is where a lot of the healing goes on. What we've looked at here, and Levine has been the biggest proponent of this, has looked at sleep analysis and when they power function. And what we tend to see is that patients in stage 1 and 2 tend to power function in those stages. And you tend to see it less in the REM. So what that means is in the deep stage of sleep, they don't tend to power function because the central pattern generators are switched off. So if they're getting poorer quality of sleep, then the risk is that they're more likely to power function. Then we look at gut health and think, does that have an effect on sleep quality? So when we look at clump size, so not breaking our food down properly, we have a change in the microflora. And the microfloral change also has an effect on sleep quality. So you then get less deep sleep, and possibly, and this is still a very weak link at the moment, where you probably get more stage 1, 2, and therefore more power functional activity. So if we can get the patient's gut health right through designing the teeth correctly, then there's a chance that we'll also improve their sleep quality. Now, that is just one jigsaw piece of a very complex puzzle, because if your patient is eating chocolate, it doesn't matter what you give, what teeth you design. So there's also what they eat. And Professor Felice from the Australian group said that the best diet is the Mediterranean diet for gut health. And that gives better sleep quality. So that's me just touching on mastication. What about swallowing? And is that important? Well, we've already stated that the 3 main jobs are mastication and swallowing and phonetics. So we need to break down and analyze each part. So within Palmeyer's paper, and Palmeyer was the big author on this, what we realized is that actually most of our chewing contacts and our swallowing contacts are in ICP or centric occlusion. Very few of them are in so-called centric relation. So it tends to happen within this functional envelope. Lateral excursions, you don't tend to get a lot of lateral movement in a chewing cycle, but that could be because they've verticalized the chewing cycle. So the data we are collecting more and more now is that what are our patients? So I don't know if any of you saw Francesca Violetti's webinar yesterday, for which I was hosting, and we were talking about her classification for patients who have a masticatory habit and what types they are. Because I think this is what we will be doing over the next 5 to 10 years, is classifying our patients, because we can see our patients. But with bruxism, there is a real pattern to it. It's haphazard. There's no fixed way, but this is how they power function. Their duration time is different. Their patterns are different. So it's not going to be the same as mastication. So you have swallowing contacts. So that's what we want. Centric occlusion, good stable contacts distributed amongst as many teeth as possible. When it comes to phonetics, the central incisor is an essential tooth, but it's essential in its three roles. One of its roles is purely aesthetic. The other role is it has a functional but also an aesthetic role, the incisal edge. And then the palatal aspect is purely functional. So it means getting our central incisor shape right is really important, not just from an aesthetic point of view. So when we look at a phonetic analysis, we tend to do two analyses, F and S. But my main one is S. Silverman was the big proponent of this, looking at vertical dimension and sounds. And with Modjaw, I can actually analyze those phonetical sounds to see that whether I've positioned my incisal edge. And the literature says that if within, as long as you are no less than 0.2, ideally between 0.2 and 1 millimeter, you will have good phonetical sounds.
55.
So 2 words I get them to say, 55, 55, 55. And for S's, it's 66, 66, 66. So you will notice with your patients, they will have 2 types of movement, either a more horizontal movement to get the S sound, more common in class 2, or a more vertical sound. When we look at analyzing occlusion, we need to understand the equipment that we use to analyze. And most of us are using articulating paper. And when you use articulating paper, you have to understand the limitations with the system you have. You have to understand the difference between a smear and a contact. You have to be able to standardize those forces, but also which one do I adjust and how do I adjust? So when we look at cases like this, if you understand the principles of occlusion, you will know what to adjust and what not to adjust. This was an interesting case where a patient had had 20 crowns done, 5 to 5, upper and lower, and her natural teeth, 6s and 7s, are not touched. So when we look at the assessment, she's got a class 2 skeletal with an anterior open bite, so a large overjet, but the only teeth touching are the second molars. You can see the articulating paper. So we're going to test run a set of prototypes, a new occlusal scheme, to see if this will work for the patient. So using the Modjaw data, I've done the movement analysis. So I've got mastication, lateral intrusion, and we are now using Exocad, digital planning software, to analyze that motion data and design the provisional restorations. So we end up with a set of restorations that look like this. So I'm doing 1 quadrant at a time. And what I noticed straight away using Modjaw data is that the teeth shape much more natural looking. Look at the distobuccal cusp of that upper 6. Look at the cycle in pathways. They are similar. That's what we want. We want good motion data. So these are the provisionals in situ, good static contacts, but look at the good functional contacts as well. When you analyze occlusion, you can ask them to do it this way, but this is not their functional occlusion. This is a habit-based occlusion. What we really want to know is how they chew. So we ask them to open, move the jaw to the right, and this is what we want to see. We want to see good movement. So buccal cusp guiding in, and cycle out. So let's go through a case of how we would do the analysis of a case to get to an end point where we have potentially rehabilitated the patient. And this case is complete, but I'm just waiting to do one more Modjaw analysis about 3 to 6 months after I've fitted the provisionals, after I've fitted the finals. So we have a case here, and his complaint is purely aesthetic. He's 63, he's a non-smoker, and he's had a lot of dentistry over time. When we look at his overall analysis, we've done a soft tissue and a hard tissue analysis. So he's got a Miller's class 1 on the session. Is a class 3 in size and skeletal relationship with an overjet overbite measurement. OVD is reduced, so we are already finding some issues here. His functional movements are group function left and right, and his first tooth contact when his muscles are relaxed is on the upper left 7. His protrusive guidance, though, interestingly, because he has no overjet, is off the posterior teeth. So we've got an opportunity here. So we have a diagnosis, we have some soft tissue diagnoses, we have some hard tissue diagnoses, and we have some occlusal diagnoses. So we have an occlusal issue as well. You do your full charting. I always do a full perio charting and a plaque and bleeding score because I really want to know what my starting point is. So they need to be below 15% before we start embarking on any indirect work. So part of my treatment plan is to look at an aesthetic functional analysis now. I am rebuilding the occlusion, and we've discussed a connective tissue graft because I want to bring the canine gingival zenith down, and I was planning to do that with soft tissue grafting. And then we would be in provisionals. We would adjust those provisionals, correct the endos, and do its final restoration. So you can see the position of the canines. So these are quite challenging because we don't have a lot of keratinized tissue, but this is what I wanted to achieve. The patient has listened to my argument and my treatment plan. So he's told me what he desires. I have done my suitability assessment. I've come up with my treatment plan for him. I've told him how much it costs, and he's decided I don't want any soft tissue grafting. So he's cut out any surgery. He just wants the teeth fixing, and he accepts that the canines will look longer. That's fine because it's his desire. How I record centric relation, and you'll see that it's done sitting up, not lying down. If you're making a splint for the patient to wear at night, then you can record the patient lying down. But if you're going to record to rebuild the teeth, why would you record it with the patient lying down? That's not they don't chew their food when they're lying down. We need to record it with the patient upright. So this is me recording that first tooth contact with relaxed muscles. This is what we need. You can use a leaf gauge, you can use other techniques, but my preferred way is to have less muscle activity. So the first tooth that touches, I said it was the upper left 7 from a clinical perspective. I'm actually just checking that from a digital perspective. Have I got that right? So you'll see here that I'll just reduce the translucency, and then you can see that the red mark is on that upper left 7. So I'm happy that my record is correct. Then that software, that data is given to the software designer. So I in this case, I used Rebel software designed by Ivo Dimitar Fletchoff and Gallup Gurel. So we've come up with this design, and I need to test run that now. So does that look right in the patient's mouth? So you can use something called biocopy, where you scan your pre-op and then you make them in provisional. So again, cut back through the additive material. Prep's done, provisionals made. So these are PMMA provisionals in situ. And now we're going to test run that occlusal scheme. Now you can test run it for 2 weeks, anything up to 8 weeks. I tend to go for a little bit longer with my patients. So that's where we're at. That's where we're at in provisional restorations. So now I know from an aesthetic point of view, the patient may be happy. I'm going to still do an aesthetic analysis, but we're first going to check the occlusal analysis. So functionally, we have good static contacts and we have good dynamic contacts. So how do we know that? Well, we knew that his starting data was good. So I've replicated that into his wax up. And I want to check that the actual design of the provisional restorations has not changed his chewing cycle. And so again, using chewing gum, he's now in provisionals. And I'm watching how he chews the chewing gum. So he first has to start, he has to warm it up. So whatever it is like in the first 10 to 15 cycles, I don't trust, because what we've got here is a hard chewing gum which needs to warm up. It needs to become softer. So the way to think about it is that the upper teeth are the garage for your jaw movement, and the teeth are the car. And so we've got to design the teeth. We've got to get that teeth to fit within the garage. So the upper restorations have to be designed to allow for the car, the lower movement, to be harmonious. So when we look at it, it's very similar to what we were at the start. So we have a good occlusal envelope of function, a good masticatory envelope of function in the provisional. So I know now I've designed those teeth to stay the same because you already had good lateral movement, but I haven't made it worse. So here we've got good cycle in and a good cycle out pathway. So he is quite a horizontal chewer. So now using that data, we're now designing his definitive restorations. So now you'll see here the cusps are being designed, the restorations are being designed. You're again using Modjaw data on Exocad. And we end up with two sets of restorations. One, I designed at a different lab. So I gave them just the scan and said, design the teeth, no motion data. And then I designed the other set of teeth with a different lab using motion data. So we had two different designs here done. Look at the cycle in pathway on the average value. Look at the cuspal heights, very different. Look at the cycle in on the average value on the left. They are different. They are different to each other. So the angles are all different. But look at the motion data, the ones designed on Modjaw. Look at the cycle in data. They are very, very similar. That for me is functionally driven restorations. You've seen us do the phonetic analysis, so I'll just jump onto the aesthetic analysis. So now I'll record a video with the patient talking. And I'm looking at the patient and I'm spotting things straight away. I think his incisors are a bit too long. His canine on the upper right isn't right. It looks too long as well. So from that video analysis, we notice static photo here that the canine isn't right as well. Patients noticed as well that his speech is affected, so we're going to correct his incisal length. That was all highlighted in the curve of SPI analysis. So here you can see how much I need to reduce that incisal length by. So now I've done my adjustments and patient feedback is important. Okay, so these are just the provisional restorations. I do the posterior first. So I'm not a fan personally of doing all the upper arch in one go. I prefer to get the provisionals right, test run my occlusal scheme before I put on new tires. So what I've done is I've given them a set of spare tires to run my the teeth in, and let's check how they run those teeth in before I start giving them a new set of tires. And I take that word from Francesca Violati. So here we've designed the teeth, happy with that, happy with the angles. Okay. So that was the design data. We then cement them in. Okay, I'm happy with that. Finish off the anteriors now. So I scan the anteriors, they get designed and fitted. So once they're fitted, a week later, I repeat the Modjaw. So I've now fitted the upper arch. Upper arch is done. I've now let him go for 2 weeks. Go on, go and test those new tires for me, please. How is the car running with it? So he comes back in and he says, everything's fine. Say, fine, not a problem. Let me have a look. So we take a new Modjaw data. So I analyze his functional data, his mastication with chewing gum, And I notice that on the left side, his chewing cycle is reduced. So when you look at the picture on the left, that was his original and his provisional masticatory data. But in his definitives, he's reduced his cycle. He's actually really narrow and he's become more vertical. Why is he adapted negatively? Why is he suddenly, but he's not feeding that back to me. He's not telling me, oh, I can't eat on my right. He's going, no, everything's fine. So when I was then, it made me look more at what we were doing. So I'm watching the patient as he chews. And I noticed straight away when he's chewing on the left side, his right teeth are touching first. So when he's chewing on the left, the right teeth are touching, he has a non-working side contact that I've introduced. Wasn't there in his provisionals, wasn't there in his natural dentition. So now he is adapted negatively. So I can see that on the Modjaw, but I'm still skeptical. I'm still cynical. I go, well, let me actually check in the mouth. Does that actually transfer? So look, as he chews on the left, watch the picture on the bottom left of your screen or the bottom right-hand side of your screen. Watch as he comes in to cycle in with the food on the left side, and he starts to hit the right side of his teeth. There you go. And when he comes out of it, look what happens. So I wanted to check that. And so it was true. It was right. He had a non-working side contact. So I adjusted it. And as soon as I adjusted it, the patient's feedback was, oh God, I never recognized that before. But actually now I can feel my jaw can move more. And so I've left him now with the coronavirus. It won't be till probably July or August when I'll repeat my Modjaw to see whether actually I've rehabilitated the patient. These are his final photos. So we've achieved the result from an aesthetic point of view, but also I wanted to really improve the functional aspect as well. For me, it's no point in, I can deliver aesthetics. I think that's not too difficult for me personally, but function is what's really challenging. For those of you that may be interested, I am running a day webinar. It's a masterclass on the 23rd of May. Normally the cost for that would be a lot more, but we're just reducing it down to £50 just to really help people in sort of the difficult times we're in. To register, there's the link at the bottom, so you can screenshot that if you want. And then that's me done.